Good morning. My name is Lea Wildermuth, and I am a MPH candidate in my second semester at the Boston University School. As my midterm for IH743, Implementing Health Programs in Developing Countries, Making Programs Work, I will be discussing quality improvement in the Guinean NGO Treatment for All, a plan to improve patient flow and decrease patient wait times in a total life clinic, an ART clinic in Conakry. Over the next several minutes, I will outline for you the clinic's needs, offer potential recommendations, discuss anticipated challenges, and provide a step-by-step plan to address the scope.
Let me provide you with a brief introduction to Treatment for All and the Total Life Clinic. Treatment for All, or TFA, was first established in Conakry, Guinea in 2001. Funded primarily by PEPFAR, TFA seeks to improve the clinical care and treatment of individuals living with HIV and AIDS. They aim to achieve this through the formation of partnerships with the private sector and other NGOs to provide the people with safe, effective, and affordable
In Conakry,
ART. TFA runs the Total Life Clinic, which offers HIV testing, treatment, and
2010, the Total Life Clinic cares for approximately 18,000 patients on ART. This averages out to over 3,800 monthly visits and 179 visits a day, in conjunction with the 129,000 patients they see annually for pharmacy visits.
Staff face challenges efficiently treating this ever-growing number of patients, resulting in overly long patient wait times. Patients attending the clinic for medical visits, on average, spend 3.5 to 4.5 hours per visit, with only about approximately 10% of that actually with a nurse or doctor. Pharmacy visit patients spend approximately 2.5 hours per visit, again, not even seeing a doctor.
In addition to excessive patient wait times, the clinic's file registration and recording system integrates humans and computers, patients, and staff, making it complicated and inefficient. This results in exceedingly overworked staff and subsequently questionable and inconsistent quality of care, as well as reduced patient and staff satisfaction.
As a quality improvement consultant for TFA, I would like to formulate a team to analyze current patient flow, registration procedures, and arrival times to create a series of interventions that could be used to improve patient satisfaction. If human resources allow, staff and patient surveys will also be distributed to get in-house opinions to what exactly is causing long patient wait times. Potential strategies will then be offered, as well as a monitoring and evaluation plan that will use indicators established from the clinic's original structure and data to track the success of each new strategy and enable alterations
Based on the
if needed.
previously distributed surveys, staff and patients report 3 primary issues contributing to the clinic's overly long wait times. First is the clinic's lengthy and clunky registration process, sometimes taking up to 70% of the patient's entire visit. Second, patients believe there to be an insufficient number of clinical staff. Given the number of patients the clinic sees annually, this is likely true. However, poor patient flow mapping can result in similar effects. And third, patient bottlenecks are occurring due to patients arriving in unequal proportions throughout the day. Over 52% of patients arrive before 9:30 a.m., leaving staff to scurry to accommodate more than they can in the mornings, yet leaving the later afternoons very quiet.
To combat these issues, I propose 3 possible solutions. First would be a new registration and file retrieval system, preferably 100% computerized to increase ease and speed of data inputting and file retrieval. This intervention would reduce waiting time between entry and registration and when the patient sees a nurse or a pharmacist. While an electronic system would be ideal, if budget constraints remove this option, additional registration staff could be hired or an appointment book could be introduced. An appointment book that schedules by the hour rather than simply by the day would improve appointment distribution throughout the day and decrease the risk of bottlenecks occurring. It would also help staff to keep better track of each day's patients, enabling them to separate the files of expected patients and curtail the retrieval process. Lastly, altering the current patient flow map will help streamline patient visits. This could be done by reducing the number of providers patients see per visit. One nurse could take both vitals and capture data. In conjunction, a system would be implemented to classify patients as stable or unstable. After registration, stable patients will be seen by either a nurse or a counselor who will ensure that they are still in acceptable health and order labs and further testing if necessary. They will then be put on an automatic refill program, consolidating the time they spend waiting at the pharmacy. Unstable patients will continue to follow the current patient flow map, with the exception of nurse number 2. This adjustment will relieve doctors from attending to all patients and allow them greater consultation time with those in need.
Finally, we are likely to meet challenges in our attempts to implement these different solutions. Financial barriers may cause problems implementing a new registration system. Like financial barriers, human resource barriers will also cause us to likely need to get creative. Because we cannot simply just hire more clinical staff, we may need to change the patient flow map or also the structure of the organization to be more efficient in reaching patients. Lastly, cultural barriers are likely to cause problems. In certain countries, governments inhibit nurses from being the ones to prescribe HIV/AIDS related medications. Also, patient care and patient adherence to our new policies may vary depending on their interest in being cared by nurses rather than doctors. Thank you very much for watching my short video, and I hope I answered everyone's questions.